Hello, citizens of Internet. I am Professor Ajit Virkud from Mumbai, India. Today, I will discuss a chronic lifestyle liver disease known as non-alcoholic fatty liver disease (NAFLD) and its complications, primarily non-alcoholic steatohepatitis (NASH). You may be wondering why a gynecologist is discussing this gastroenterology topic. There is a valid reason. Gynecologists see many patients with polycystic ovarian syndrome. PCOS is a predisposing factor for non-alcoholic fatty liver disease. Therefore, every gynecologist should conduct long-term follow-up of patients with PCOS. Furthermore, many young working women consume a significant amount of junk food ordered online, making them prone to obesity and metabolic syndrome, which are high-risk factors for this condition. Consequently, gynecologists, as primary care physicians, can play a pivotal role in raising awareness of this liver disease among their patients and preventing its development. However, for this to be achieved, they must possess knowledge of non-alcoholic fatty liver disease, particularly its diagnosis, prevention, and treatment. They should be able to diagnose fatty liver disease in the early preventable stage, and if they encounter a patient in the late irreversible stage of NASH, they should emphasize the need to refer the patient to competent hepatologists for further management to minimize patients' morbidity and mortality due to this disease. This is part 1, where I will be discussing general aspects of the disease. In part 2, I will talk about the diagnosis and management of NAFLD. First, let me delve into some historical aspects. I like to refer to this as the ABC and N of liver disease. In the first half of the 20th century, the most prevalent liver disease seen in the population was hepatitis A. This was primarily due to the lack of clean filtered water, poor sanitary conditions, and the frequent contamination of food. During our student days, we witnessed an epidemic of hepatitis A. Fortunately, over time, the prevalence of hepatitis A declined thanks to improved living conditions, the availability of filtered water, and the development of mass immunity amongst the population. By the second half of the 20th century, another hepatitis emerged, post-transfusion hepatitis. Initially, doctors were not aware of this cause. However, in the late 1960s, Australian researchers made a groundbreaking discovery. They identified the hepatitis B virus, which was first detected in an Australian aborigine, and subsequently it was named the Australia antigen. Hepatitis B is an asymptomatic but highly contagious liver disease that can lead to complications including cirrhosis of liver and hepatic cancer and finally death. Despite these challenges, the medical community has successfully contained and is actively working towards eliminating hepatitis B through measures such as compulsory pre-testing of blood for the presence of the virus before blood transfusions, mass vaccination programs, and the availability of effective antiviral drugs. Subsequently, another virus surfaced causing hepatitis. Initially, it was termed as non-A and non-B hepatitis because we did not know what caused this liver disease. In the late 1980s, researchers identified this virus as the hepatitis C virus. Hepatitis C has dominated the field for several decades. Its clinical features are similar to those of hepatitis B, and like hepatitis B, it can also result in severe liver damage and death. Fortunately, drugs prescribed for a few months can effectively relieve the human body from the harmful effects of this virus. While humanity was diligently recovering from these three viruses, a new liver issue emerged at the beginning of the 21st century and quickly became a global epidemic. This disease poses a significant threat to the younger generation. Citizens of Internet, this condition is known as non-alcoholic fatty liver disease (NAFLD). Unlike viruses, toxins, or drugs, NAFLD is solely a consequence of unhealthy lifestyle. To some extent, the millennial generation as well as the Gen Z and Gen Alpha has become increasingly sedentary. With the convenience of online shopping, their every need is readily accessible. Many of them spend extended hours sitting in front of the computer screens, leading to a sedentary lifestyle and stress from work, which often results in the consumption of non-nutritious processed foods. This combination of factors has made them susceptible to various lifestyle diseases, including metabolic syndrome, PCOS in women, and now NAFLD. It is imperative that we as society take responsibility for the situation. The medical fraternity must address this disease with urgency and seriousness it deserves to protect the current generation of men and women. The first and the most crucial step is to raise awareness about NAFLD among the general public. In recent times, there has been an alarming rise in the prevalence of fatty liver disease, which has become a global epidemic. It is estimated that approximately 30 to 40% of the general population has fatty liver. A subset of this group will progress to non-alcoholic steatohepatitis, called as NASH in short, from which a small percentage will develop complications such as cirrhosis of liver and hepatocellular carcinoma. Another concerning statistic is that about 20 to 30% of patients with non-alcoholic fatty liver disease without advanced fibrosis or cirrhosis can develop hepatocellular carcinoma, and these numbers appear to be increasing. There are numerous terminologies employed to describe the patient's fatty liver disease. As a fundamental aspect of medical knowledge, it is crucial to comprehend the diverse nomenclatures used to categorize various forms of this liver condition. Regrettably, these terminologies are frequently employed interchangeably. Terms such as fatty liver, non-alcoholic fatty liver, NAFL, non-alcoholic fatty liver disease, NAFLD, MET-ALD, non-alcoholic steatohepatitis, NASH, liver fibrosis, and liver cirrhosis are employed to categorize various liver-related conditions. I will provide a comprehensive explanation of each of these terms. The term fatty liver is used to describe a condition where at least 5% of the liver is replaced by fat. Non-alcoholic fatty liver simply implies presence of greater than or equal to 5% steatosis, that is fat accumulation in the liver without any signs of injury, that is inflammation. The diagnosis can only be confirmed through a histological examination. Non-alcoholic fatty liver disease encompasses a broad spectrum of fatty liver diseases in individuals who do not have significant alcohol consumption. MET-ALD is the term used for individuals who have metabolic risk factors and suffer from alcohol-related fatty liver disease. The term non-alcoholic steatohepatitis, that is NASH, is characterized by the presence of 25% or more steatosis, that is fat accumulation in the liver, accompanied by liver injury such as hepatocyte ballooning or fibrosis. Cirrhosis of the liver is permanent scarring that destroys the liver and interferes with its functioning. It can lead to liver failure. It is the persistent liver damage over many years. Although alcohol, drugs, viruses, and metabolic factors can cause cirrhosis, non-alcoholic fatty liver disease is the commonest cause. From the provided descriptions of these terminologies, it appears that the conditions are watertight. However, the situation is not as straightforward as it may seem. This circle, which represents the global population, depicts various types of fatty liver conditions. It is crucial to recognize that many of these conditions can coexist, as one liver disease can predispose an individual to another type of liver condition. For instance, consider the case of MS plus NAFLD. In this scenario, a patient with metabolic syndrome later develops NAFLD because diabetes, hypertension, and dyslipidemia are significant risk factors for fatty liver disease. Another example is a person suffering from alcohol related fatty liver disease, which can later develop non alcoholic fatty liver disease even after ceasing alcohol consumption. Recently, experts have recommended changing the name non alcoholic fatty liver disease to metabolic dysfunction associated steatohepatitis MASH. To clarify the distinction between alcohol related fatty liver disease and non-alcoholic fatty liver disease, it is essential to understand the criteria for significant alcohol consumption. Men who exceed 21 standard drinks per week are considered alcoholic, while women typically consume more than 14 standard drinks per week. Individuals with fatty liver who meet these criteria are diagnosed with alcohol related fatty liver disease. Conversely, non alcoholic fatty liver disease does not exclusively refer to individuals who abstain from alcohol entirely. Even if individuals consume alcohol in moderate amounts, as defined above, and develop fatty liver disease, they are still classified as non alcoholic fatty liver disease. I trust this clarification is satisfactory. This diagram beautifully illustrates the various stages of non alcoholic fatty liver disease, NAFLD. Patients can transition between stages, but there is considerable reversibility in the disease's progression until it reaches decompensated liver disease, commonly known as cirrhosis. It is important to note that only 20 to 30% of NAFLD patients progress to non alcoholic steatohepatitis NASH, and of these, only 5 to 18% further develop complications such as liver cirrhosis. The progression from one stage to another is influenced by the presence or absence of other comorbid factors, including diabetes, hypertension, and dyslipidemia. Additionally, certain genetic factors may play a role in the disease's development. In this section, I will elucidate the pathophysiology of non alcoholic fatty liver disease. Despite the diagram's complexity, I will endeavor to simplify the explanation of the liver disease's pathophysiology. When the liver accumulates fat, it undergoes a process of rancidity, similar to how oil deteriorates when exposed to air for an extended period. This lipotoxic fat triggers inflammation within the liver primarily through the activation of stellate and Kupffer cells. This inflammation leads to the death and destruction of liver cells, that is, hepatocytes. Over time, as the liver undergoes this process, more and more of its tissue is damaged and replaced by fibrous tissue. While the scarred liver can regenerate, complete destruction and scarring of the liver prevents regeneration. This condition is known as liver cirrhosis. During the regeneration process, sometimes there is a risk of mutation of liver cells and subsequent cancer development, particularly hepatocellular carcinoma. These microscopic images depict the histological features of steatosis and non-alcoholic steatohepatitis NASH. Slide A at 200x magnification illustrates macrovesicular steatosis characterized by distended hepatocytes surrounded by large fat droplets stained with chromotrope aniline blue. Slide B at 200x magnification with hematoxylin and eosin, that is HNE staining, demonstrates NASH characterized by ballooned hepatocytes with lightly stained cytoplasm, some of which contain indistinct cytoplasmic inclusions resembling Mallory Dank bodies, MDBs. Slide C represents a more advanced stage of NASH with ballooned hepatocytes, some of which contain MDBs indicated by arrows. Additionally, most hepatocytes are surrounded by pericellular fibrosis, shown as blue rims around hepatocytes, as evidenced by the chromotrope aniline blue stain. Inset D at 200 magnification is an immunohistochemical image using antibodies to sequestome 1/p62, which reveals p62 containing MDBs, colored red. What are the morbidity risks associated with fatty liver? Fatty liver disease is associated with the affection of multiple organs in the body. It can lead to brain dysfunction, that is, dementia, sleep apnea, thyroid dysfunction, hypertension, heart blockages, gallbladder stones, chronic kidney disease, diabetes, non liver cancers, menstrual irregularities, and polycystic ovarian syndrome. What are the mortality risks of fatty liver? Now, why should a person having fatty liver worry? The commonest cause of death in a person with fatty liver is actually heart attack, cardiovascular event, seen in 38% of cases. 20% of individuals with fatty liver will die because of non-liver cancers, and liver-related deaths occur in only about 9% of these patients. In the next two slides, I will discuss the various secondary causes and predisposing factors of non-alcoholic fatty liver disease. Fatty liver disease is a consequence of unhealthy lifestyle. It can be caused by various factors including sedentary lifestyle of urban populations, excessive calorie intake, lack of exercise, obesity, particularly in Asian individuals with central obesity. Many of these risk factors are associated with cardiovascular disease and diabetes. Secondary causes of non-alcoholic fatty liver disease are alcohol-associated liver disease because of excessive alcohol consumption, drug-induced fatty liver disease, certain medications including tamoxifen, methotrexate, lomitapide, steroids, valproate, etc. can cause liver disease. Chronic hepatitis C, that is hepatitis C infection, especially genotype 3, Wilson's disease, which is a genetic disorder that affects copper metabolism, A. Hypobeta lipoproteinemia, lipoatrophy, which is a condition characterized by low levels of beta lipoproteins and lipoatrophy, starvation, that is prolonged lack of food, parental nutrition, that is nutritional support provided through intravenous solutions, Reye's syndrome, which is a rare but severe liver disease that can occur in children, polycystic ovarian syndrome, HELP syndrome, acute fatty liver of pregnancy, and inborn errors of metabolism, which are genetic disorders that affect various metabolic processes. For example, lysosomal acid lipase deficiency, also known as Wolman disease, lecithin cholesterol acetyl transferase deficiency, and cholesterol ester storage affection. In terms of clinical manifestations, non-alcoholic fatty liver disease frequently presents without any noticeable symptoms. However, when symptoms do occur, they may include fatigue, general discomfort or malaise, and pain or discomfort in the right upper quadrant because of enlargement of liver. In the later irreversible stage of cirrhosis of liver, however, patient is symptomatic. Patient will develop classical symptoms and signs of liver cell failure like jaundice, itchy skin, ascites, shortness of breath, swelling of legs, spider-like blood vessels just beneath the skin surface known as palmar erythema, enlarged spleen. This concludes part 1 of my comprehensive masterclass on non-alcoholic fatty liver disease, NAFLD. The subsequent part will delve into the diagnostic and management aspects of NAFLD. If you want to know more about this topic or any other topic in obstetrics and gynecology, please refer to my books Modern Gynecology, Modern Obstetrics, and Practical Obstetrics and Gynecology, and other books. For purchase inquiries, contact me on this WhatsApp number. I have also published 2 question answer books which are particularly useful for exam going students. These are Clinical Cases in Obstetrics, 1000 plus questions and answers, and Clinical Cases in Gynecology, 1000 plus questions and answers. You can also follow me on other social media platforms like Facebook or Meta, Blogspot, and Instagram. The links are given here. If you enjoyed this video, hit the like button, share it with your friends, and also subscribe to my channel for more videos like this. Thank you for watching.